All right, well, welcome back, everyone. We are now going into the public comment portion of our day. We are delighted to have some associations and organizations with us. Please, commenters have had the option to send in their written comment to CARB at HHS.gov. We have our live commenters here today that have pre-registered, and I am delighted to welcome John Alter from the AMR Action Fund. You have the floor.
Yep. Thank you, Jomana and PACCARB members. My name is John Alter, and I lead the External Affairs team for the AMR Action Fund. Thank you for the opportunity to provide recommendations on the U.S. government's role in addressing AMR in conflict zones, which will be the subject of Panel 3 tomorrow. While conflicts in Ukraine and Gaza dominate the news, worldwide, at least 110 armed conflicts are ongoing. As the fund's CEO, Henry Skinner, wrote in this winter's Harvard Public Health, the causes of AMR in conflict settings are multifactorial. Soldiers sustain catastrophic injuries and can require international transport. Hospitals, care centers, and ad hoc clinics become overburdened and lack basic supplies and infection control capacity, as noted by the patient advocate from Ghana we heard from previously. Civilians are displaced and may be relocated to refugee camps, and damaged infrastructure leads to poor sanitary conditions. The danger of the conflict itself is paramount, but the impact of uncontrollable infections is deadly too. As the world's largest investor in the development of antimicrobial treatments, the AMR Action Fund is committed to enabling the launch of up to 4 new antimicrobials by 2030. However, longer-term policy changes are necessary to make the innovation ecosystem sustainable, to reinvigorate the antibiotic and antifungal pipelines, and support enhanced defense and surveillance measures. We recognize the need to strengthen U.S. leadership globally to meet this critical moment in the fight against AMR and offer the following policy recommendations. First, invest in targeted antimicrobials to overcome rising biosecurity threats identified in the recently updated U.S. government policy for oversight of dual-use research of concern and pathogens with enhanced pandemic potential. The select agents and toxins subject to the policy include several bacterial pathogens that pose a significant threat to biosecurity. While the Strategic National Stockpile serves as a repository for antibiotics and medical material that can be used in the event of the outbreak, they are often broad spectrum, and the market for R&D continues to decline as these pathogens evolve. We recommend that the U.S. replace volume-based procurement with a subscription model framework for critical need antibiotics via multi-year contracts to ensure adequate solution for rising biosecurity threats. Second, we urge sustained CDC funding for detection and surveillance to better monitor and track priority bacterial and fungal pathogens in accordance with the 2024 National Blueprint for Biodefense recommendations. Third, increase collaborations among federal agency, university, and professional society partners to incentivize research and training programs in areas that intersect with AMR, similar to the comments made this morning by IDSA's Amanda Jezik. Next, develop institutional federal research mechanisms that allow infectious disease trainees to easily identify and meaningfully interact with qualified potential mentors at the federal and institutional levels. And finally, appoint a federal champion for AMR to represent U.S. policy positions on the global stage. Thank you for your leadership, and please contact us if we can assist in advancing the solutions in combating AMR.
Thank you, Mr. Alter. On behalf of the AMR Action Fund, I'd like to call on Jim Boyce from NIAID next. Mr. Boyce, are you with us? Okay. Next, we'll go to Dr. Samir Qadri, NIH Clinical Center.
Thank you, Jomana. I'd like to start by saying that this has been a wonderful meeting, and I applaud everybody's efforts. I am an ICU clinician and AMR epidemiologist at the NIH Clinical Center in Bethesda. And I'm here to provide some suggestions to you guys about AMR data and metrics and how we can do better. The COVID-19 pandemic showed us that critical and timely data are really essential, and the dissemination of that is essential to move the dial for action. Why can't we do the same for AMR? The US is a developed nation. We're sitting on a lot of data. Unfortunately, the data is siloed. And I believe that the PACCARB has the power to make recommendations such that the wand is moved up at a very high level that may result in dissolution of these firewalls so that de-identified data could be accumulated around AMR, and we could use those data to apply more sensitive metrics, not only mortality, but other non-mortality outcomes as well, disability, morbidity, readmission, nursing home stays. These are all important to clinicians and to patients who have AMR infections. And while it's difficult to attribute the impact of the interventions to the outcomes that we see, I think if we see improved mortality and non-mortality outcomes for patients with resistance, I think most people will agree that PACCARB has done its job.
Thank you, Dr. Khalji. Thank you for joining us. Next slide. Virtually, I would like to call on Tara Burke from AdvaMed. Are you with us?
Yes, I'm here. Can you hear me?
Yes, we can hear you. The floor is yours.
Okay, great. Thank you. Good afternoon. My name is Tara Burke, Vice President of Payment and Healthcare Delivery Policy at the Advanced Medical Technology Association, or AdvaMed. AdvaMed is the world's largest medtech association, and its AdvaMed DX division represents over 70 of the world's leading manufacturers of in vitro diagnostics, including large, small, and startup companies. Thank you for this opportunity to share our perspectives today. In vitro diagnostic tests serve as a cornerstone in combating AMR. Diagnostic tests are pivotal for accurate identification and differentiation of bacterial from viral infections, which significantly aids in the judicious use of antimicrobials. By assisting healthcare professionals in determining the most effective treatment strategies, diagnostic tests significantly reduce unnecessary antibiotic prescriptions and help stem the tide of rising resistance. Our industry continues to innovate, developing advanced diagnostic tools that not only provide faster and more accurate results, but also ensure appropriate antibiotic stewardship. These technologies allow for the rapid detection of pathogens and their resistance patterns, enabling targeted treatment that is both effective and economical. The role of diagnostics in managing sepsis, tuberculosis, and other critical conditions has proven to reduce hospital stays and healthcare costs significantly. The diagnostics industry is committed to ensuring timely access to these innovative technologies needed to mitigate the impact of AMR and support efficiencies in health systems. We believe AMR policy should strengthen access and utilization of diagnostics, including recognition of the critical role they play in AMR stewardship programs, as well as the role they play in supporting evidence generation through surveillance. A key driver of adoption of in vitro diagnostic tests to further AMR is appropriate reimbursement pathways. Implementing reimbursement policies, including those for Medicare beneficiaries that support the uptake and implementation of such technologies, will help reduce inappropriate prescribing practices and lead to improvements in patient outcomes. We appreciate that the current National Action Plan on Combating Antibiotic-Resistant Bacteria includes within it a priority to develop incentives and reimbursement strategies to support uptake of diagnostics. We believe this is a step in the right direction, but believe more can be done, particularly through expansion of existing programs within the Centers for Medicare and Medicaid Services. Thank you again for this opportunity. We look forward to continuing our collaborative efforts with all stakeholders to overcome the challenges of AMR.
Thank you for joining us, Tara, on behalf of AdvaMed DX. Next, we have Megan Coffey with the International Rescue Committee. Megan, are you with us?
Yes.
All right, floor is yours.
Great. My name is Megan Coffey, and I'm an infectious disease doctor here in New York City. I'm at NYU here in New York, but I'm here as the Communicable Disease Advisor for the International Rescue Committee. We're an organization based in New York City that works in 35 countries, up to 50 at a time, working on helping people respond to conflict and disaster. And so we're working with the most vulnerable people. And I think for too long, and I think this group, I'm preaching to the choir here, we've often seen AMR as not a primary issue and not as a population that was affected, whereas we're finding incredible levels of resistance, of course, in the populations where we work. And we're working particularly in 3 countries, Nigeria, in areas affected by Boko Haram in the Northeast, in South Sudan, and in Yemen, all countries that have been affected by conflict and where we've been seeing incredible levels of AMR. We're working with USAID, BHA, to form a technical advisory group because I think it's incredibly important for a number of the different actors we often talk amongst ourselves, and MSF, Africa CDC, IMC, US CDC, all part of this to try to really advise on how we can think more about humanitarian conflicts and these vulnerable populations. And it's AMR in these crises where increasingly climate change is hitting against violence, is hitting against mobility, that we are seeing real perfect storms for creating AMR. So the malnutrition, if you've never gotten to see a malnutrition ward, that's great. It tends to be a place where you have the most vulnerable children together, all sick, all having diarrhea, needing antibiotics, having measles, having malaria, having cholera, and all of these overlaying levels of antibiotics. We end up with incredible resistance. We have outbreaks, we have empiric use of antibiotics. Most people in humanitarian conflicts are children, so pediatric infections, and of course IPC, no running water in facilities, no gloves, no supplies for PPE, and needing to really change the culture in order to have care really center on making sure we're doing no harm, having no IPC concerns, and then recognizing that communities themselves, how they understand their health problems. If you've come out of a conflict, you're relying on yourself, you're relying on your family, relying on your community. And we found that in these areas that we've been studying, particularly that 4 out of 5 people reported that they had taken antibiotic before they came to the clinic. And also that 4 out of 5 of their youngest children had had an antibiotic before coming to the clinic. And that almost everyone had had an antibiotic in the last year, and that 5% only of children had not had an antibiotic. So just recognizing the really high level of antibiotic use and the need to understand it's more than just microbiology, understanding really how communities are using antibiotics, how they understand the infections, whether they think they need to take an antibiotic to prevent a cold, to prevent diarrhea, and then also understanding vaccine hesitancy has really changed in the wake of COVID, and understanding how we're really meeting these needs. And that's it. Thank you for having me. Over.
Megan, thank you so much for joining us on behalf of the International Rescue Committee. Next, we have David Gross from Arkstone Medical. David, are you with us? David Gross, Arkstone Medical. Oh, there you go. Hi. Can you hear us? We can't hear you.
Can you hear me now?
Yes. Thank you for
sorry
joining.
about that. Thank you. So thank you. I'd like to thank you for giving me the opportunity to speak today. My name is David Gross. I am the co-founder of Arkstone. At Arkstone, we are pioneers in the field of antimicrobial stewardship, leveraging cutting-edge technology to combat the growing threat of AMR. And we offer precise infectious disease treatment guidance, ensuring that physicians are empowered with the knowledge they need to make informed prescription decisions. So I commend the work being done by the committee and my fellow colleagues in the global fight against antimicrobial stewardship, resistance, but I'd like to make a strong call to action. Often we get distracted by defining, discussing, and analyzing the issue, but then stop short of actually trying to solve it. So before breaking for lunch earlier today, there was a great discussion among the panel about the need for diagnostics coupled with prescription guidance. And just earlier, there was talk about labs needing more infectious disease expertise. So I've been sitting here watching this all day and waiting to tell you this isn't a future aspiration, it's here now, and we have it today. Companies like Arkstone are at the forefront of addressing this issue. We're in the midst of an AI revolution right now, and at Arkstone, we'd like to define AI as antimicrobial intelligence. We integrate directly with diagnostic laboratories to provide precision-guided infectious disease treatment guidance to physicians at the moment they receive their lab results. So this helps them make informed decisions ensuring that the right antibiotic is chosen for the right infection at the right time. And in many situations, we actually recommend the use of no antibiotics at all. By integrating with ArcStone, physicians have instant access to infectious disease expertise, regardless of the size or staff of the lab. So this allows any lab anywhere in the world to bring actionable infectious disease knowledge to their users through our global guidance feature, which are bringing infectious disease guidance everywhere in any language, while also taking into consideration the specific needs of that region, whether developing or resource limited. So the chasm of knowledge when it comes to proper antimicrobial use can't be overstated. Despite the critical advances we've made, antimicrobial stewardship remains relatively obscure. Laboratories routinely test sensitivities for dozens of drugs, many of which are not relevant to the specific infection being treated. And this often leads to misguided prescription practices, contributing to the rise of antibiotic resistance. And molecular testing was an exciting development since it unlocked the potential of identifying resistance genes, but many doctors did not understand the results and actually overprescribed antibiotics because of that. Unfortunately, the reaction from CMS and some private insurance companies was actually to cut reimbursement for some types of testing and discourage its use. And this is not the correct response. We should not avoid new technology due to lack of understanding, but rather embrace it and educate ourselves on how to apply it so that it can be part of the solution. Solutions like ArcStone's can make the data valuable and usable, helping doctors prescribe responsibly, leading to proactive antimicrobial stewardship and improving patient outcomes. So insurance companies and government agencies hold significant power to mandate, reimburse, and push for the adoption of technologies that facilitate real antimicrobial stewardship. Incentives drive innovation, and by incentivizing clinicians and healthcare institutions to participate in stewardship, we can drastically reduce the number of prescriptions written empirically, where antibiotics are prescribed based on guesswork rather than specific actionable data. I implore those of you on this committee listening in today in positions of influence to embrace new technologies and incentivize the use of services like ArcStone that provide antimicrobial stewardship with every infectious disease result. By doing so, we can ensure that doctors are writing prescriptions correctly, actively reducing the misuse of antibiotics, shortening the duration, and in some cases, avoiding the use of antibiotics altogether. Last year, one of my fellow co-founders actually addressed this committee. Now, while there were some nods of recognition from the assembled group, nothing more came of it. But in the years since, ArcStone alone has generated 250,000 treatment recommendations for physicians based on lab result data from labs across the US and parts of South America. So let's work together. Let's not yet another year go by without taking the action we can do to save millions of lives. Thank you very much for your time.
Thank you, David. On behalf of ArcStone Medical, appreciate you joining us. And that wraps up our public comment section. Next, we'll transition to the Innovation Spotlight. As you all know, to highlight new and emerging technologies in the fight against AMR, we're excited to continue this public comment portion to our meetings that's dedicated more to startup companies and innovations to showcase their work in the battle against AMR. Like our traditional public comment section of the day, pre-registered companies have an opportunity to share their work with all of us. The spotlight was open to all interested companies with a technology directly related to combating AMR, and each presenter will have 5 minutes, and there will be no Q&A portion following each speaker. Next, we have, I believe we have a public commenter that just came in. Jim Boyce, NIID, are you with us? Sorry, we're going to go backwards. Jim, did you join? Jim Boyce, last call. Okay, we're going to keep going with the Innovation Spotlight then. Everything I said, ditto. We're just going to keep going. All right, so we are going to start with Lumos.
Hi there.
Hi, thank you for joining us, Ms. Bell. The floor is yours.
Thank you. Thank you for the opportunity to discuss FebriDx today. My name is Annie Bell. I'm the head of medical affairs for Lumos Diagnostics and conducting all the clinical research for our products there, including FebriDx. Next slide, please. So FebriDx is a simple all-in-one point-of-care assay that can be used at the bedside for clinicians who are making decisions, and the results can be used in the moment to determine whether or not a patient has a bacterial infection or a non-bacterial infection when they present with acute signs and symptoms of acute respiratory infection. So very common reason for prescribing antibiotics in the U.S. So FebriDx has FDA clearance in the U.S. for use in urgent care and emergency departments, and it can reliably differentiate between a bacterial and non-bacterial infection in patients who present with that acute respiratory syndrome. It can ensure that that bacterial infections are not missed, so in patients who do have them and could benefit from antimicrobials, and also ensures that with a high negative predictive value that for bacterial infection that antibiotics are not needed, and identifies those patients who may not benefit from antibiotics, and helps protect them from the negative sequelae associated with giving them antibiotics when they're not needed. Next slide, please. So the test works by using two host response biomarkers. The first one may be familiar to some of you, which is referred to as C-reactive protein. So C-reactive protein is an acute phase reactant that's produced in response to inflammation, including infection. It can be elevated as a potent stimulus for bacterial infection. The other host response biomarker that's used on this on our test is myxovirus resistance protein A, or MXA. And it's produced in response to viral infection. The innate immune response releases interferon, and that upregulates the production of MXA. MXA has low basal metabolic levels, and therefore it's more specific to viral infections, whereas CRP can be elevated at certain levels, are more sensitive to bacterial infections. So independent, the two biomarkers are not sensitive nor specific enough to detect or rule out bacterial infection, but when paired together, they have a high sensitivity, specificity, and negative predictive value for detecting and ruling out bacterial infection, therefore determining when patients may or may not benefit from antibiotics. Next slide, please. So it's a very simple to use test. Like I mentioned before, it can be used right in the patient visit by clinicians to make decisions about whether or not a patient has a bacterial infection and would benefit for an antibiotic, or more likely does not have a bacterial infection and may not benefit. So the Lancet is built in. It's a retractable Lancet, so there's just a removal of a safety protective tab. And then the finger is clean, punctured with the test, and just a small drop, 5 microliters of blood is obtained, placed directly in the blood collection tube that works with capillary action. The arm is rotated, it's applied to the test, and then the buffer's released. It's also incorporated into the test, and it works via lateral flow. And then there's built-in controls and quality assurance to assure that the blood has transferred. And once the blood has transferred and about 10 minutes has passed, the clinician can interpret the test results to determine if a bacterial infection is or is not present. Next slide, please. So like I said, BeverDex is a simple point-of-care assay that's available in the U.S. currently, and it has been validated in a multi-center prospective U.S. trial with 20 point-of-care sites that were physician offices, urgent care centers, and emergency departments. BeverDex was compared to a clinical reference algorithm that incorporated bacterial culture, multiplex PCR, and measures of host immune response, and then had expert adjudication. So was compared very rigorously, basically, and was determined to be very sensitive and specific for detecting and ruling out bacterial infection. So 93% positive predictive agreement, a negative predictive agreement of 88%, and ruled out bacterial infection with almost a 99% negative predictive value. So it really gives clinicians the confidence when a bacterial infection is there and a patient really needs an antibiotic, and then supports antimicrobial stewardship by identifying when patients with a high degree of reliability do not have bacterial infection and may not benefit from an antibiotic. So it empowers clinicians in the moment with something tangible to discuss with their patients when they don't need antibiotics. And it's also a very affordable test. It's, like I said, it's a simple lateral flow assay. And that's all I have for today. So thanks very much for the opportunity and for your efforts as it relates to antimicrobial resistance.
Thank you so much for joining us on behalf of Lumos Diagnostics. Next, we have Elamino Health. Are you with us?
Yep, I'm here. Dr. Arup Roy Berman. I am founder and chief medical officer at Elamino. So I'm former medical director of the ICU at UCSF Children's. And there we struggled with how do we keep our staff on the same page with constantly changing information, complicated by constantly changing staff? And when we look at trying to get information to our people, it's really about getting them to learn. You're trying to change behaviors. And when you think about it, even for yourself and how we learn today, when we get information in large chunks, it goes in one ear and it goes out the other. How could we take critical information, of which antimicrobial stewardship was just one part of it, how could we get it in a way that it would stick? So what we realized was the best type of information is the information you get in context. When you're dealing with that septic patient, that's when I want that information, just in time. And for the information, we want it in small chunks. We see today with our staff and our team members, attention spans are getting shorter and shorter and shorter. You have a brief moment and you've got to hit it hard. And you do it in a multimedia format that people can understand, get in and get out. So what we created was a just-in-time microlearning application customized for frontline teams. Our big picture goals was how could we streamline how we would train and orient our staff on any myriad of different topics, including of which is antibiotic stewardship. And then how can we use this just-in-time context to be able to decrease variation, to be able to improve standardization, improve predictability, and thereby improve safety? And finally, how could we do it in a way that was local? Because the reality is frontline staff don't care much about national guidelines. They want to know about how does that guideline apply in my house, with my resources, with my formulary, with my patients. We need to give that customized experience that helps the staff in their house in the moment. Next slide, please. So this is, our existing world, and hopefully it all resonates with you all. The frontline experience is chaos. We've got operational information from management. We've got training coming from all of our different specialists and our educators. We're hearing system-wide standards as well as my unit-specific information, and it is sitting in binders and flyers and dumped in the SharePoint. It's thrown above the toilet in the bathroom. God knows what version that is. And in desperation, if I can't find it, I'll go to Google, and who knows what I'll find there. We take all of that and we simplify it into a one-stop shop, gated to the organization, customized to that individual unit in a multimedia format. Next slide. I'm sure all of you are familiar with the types of things on the left panel. We see this for antibiotics all the time, all types of decision guidelines. Lots of effort's gone into it. The reality is it sits in a drawer somewhere or in a binder or is shoveled up in somebody's pocket or briefcase. At the moment that it's needed, few people pull it out, find it, and are able to use it. The key is we need to make that information, one, accessible in the moment, so you can just punch it in, boom, it comes up to you, and it needs to be digestible. Take away that cognitive overload so I can just quickly answer some questions and see what I need to do. That's what we do. We transform your knowledge and we make it accessible and digestible in just-in-time multimedia microlearning. Next slide. The end result is that it works. As seen there at UCSF, one of the top-ranked hospital systems in the country, we were able to cut CLABSI 50%, getting everybody on the same page. Children's New Orleans published 75% decrease in serious patient harm. And looking also in the UCSF ecosystem in the Children's Hospital, 85% reduction in C. diff infections. We're doing this with hospitals around the country. And the beauty is that everybody is taking national guidelines or guidelines that each one is developed that is going well, sharing it with others, and adapting it to the needs of their house to give their team a very personal and relevant experience. And in this way, getting everybody engaged, whether it is antibiotic stewardship, it's about just orienting as a new nurse to various products, all of those things coming into a simple one-stop shop. Because the reality is people don't want a myriad of point solutions. They can't remember where it is. We're living in a world of connectivity. We need to bring it all together in one place and keep it personal, keep it specific to your needs, and do it in a way that management gets feedback on what works and what doesn't, and they can iterate from there. Thank you very much.
Thank you for joining us, Dr. Burnham from Elimino Health. All right, well, that concludes the Innovation Spotlight portion of our day. I'd like to thank all of our panelists for being with us both in person and virtually. I'd like to thank our council members for all of your feedback and comments, and especially our moderators for today for navigating the two panels that we have. I'm going to open it up for Dr. Plummer and Dr. Jason Newland to close us out until we prepare for tomorrow.
Thanks, everybody. Thanks to the public commenters and the Innovative Spotlight. It's a great day. Thanks to the council again for all the hard work done on the global AMR report. Super proud of all of us and getting that done. And yeah, big shout out to our PACCARB staff. All of you rocked it, and appreciate all that you did to make sure that happened. Look, I think it was amazing as usual. I think I'm still thinking about my two pets at home, Frankie and Chicken, and whether this can allow me to get rid of them. I'm just kidding. I'm kidding, Doctor. But no, I think what we love about these sessions is we learn, right? And we get to learn new things and talk about issues that are germane to what our charge has been from the beginning of PACCARB 10 years ago. And so I appreciate the discussions and everyone's inputs, and I look forward to more of that tomorrow.
All right. Thank you, Dr. Newland. I echo Jason's comments. I want to express my appreciation to all of our PACCARB council members, RGEs, SGEs, affiliates. Certainly want to thank our speakers for taking your time to share your expertise and knowledge with us. It's been a full day. We started the morning with finalizing our report on collaborative global leadership in combating AMR. And that's been a lot of work. I want to thank, as Jason did, the working group, the entire council, and particularly our staff who has worked tirelessly to make edits, to get these out for working group feedback, to line up speakers, to address topics. And we do truly have one of the best staffs that you can imagine. And so Jemana's smiling because she knows it's true. We do. And so what we do is largely because of the support they provide us. And then we continued today with several just profoundly interesting panels. You know, we saw a number of narratives and stories about the impacts of AMR on patients' lives and how important that is. And that's important to remind us of why we are doing what we're doing here today and tomorrow. And then we saw, an outstanding panel here on the companion animals and that One Health interface and just how important that is. And often how, I think as Dr. Weiss started that conversation, when we talk about animals in antimicrobial resistance and One Health, many people's minds jump to livestock and livestock production, which certainly is hugely important in that space. But the interaction that many of us have with our companion animals that live in our houses and sleep in our beds and interact with our kids and do all of the different activities. For most of us, that's a lot more interaction, as was pointed out by several speakers, than we have with livestock, for instance. So, and then finished out with some very helpful comments from public comments and the Innovation Spotlight. So as we prepare to break for today, I would encourage all the council members and staff to enjoy our evening. Be proud of what we accomplished today. Take the evening off and enjoy our fellowship and conversation. And we will start back at 9 a.m. in the morning. We have several phenomenal panels again tomorrow on conflict zones and drug resistance, and then also the unequal exposure, unequal risk, environmental racism, and drug resistance. And so HHS live tomorrow, and so enjoy your evenings.
produced by the U.S. Department of Health and Human Services.